So I will go ahead and start sharing my screen. Um, so to start, for background, brain metastasis is the most common intracranial tumors found in adults in the United States, with an estimated prevalence of 70,000 to 100,000 cases per year. Among the primary tumors, the most common types with the highest risk of intracranial spread include lung cancer, breast cancer, and melanoma. For these patients, stereotactic surgery, or as I will refer it from the rest of the talk, will be SRS, example of which include gamma knife or proton beam therapy, has become a popular intervention method in addition to resection, chemotherapy, or whole brain radiation therapy. SRS delivers a controlled, targeted, excuse me for 1 second, a controlled, targeted, and precise doses of ionizing radiation to the specific metastasis sites. For the purpose of the study, we aim to use data from a large national registry to examine SRS abilities to, one, achieve tumor control, and more specifically, two, to assess quality of life changes following treatment for these patients. In conducting the study, we relied on patient information maintained by the NeuroPoint Alliance SRS registry, which collected patient information starting in the year 2017 to now from 27 contributing institutions across the United States, with 5,500 enrolled patients and 8,400 distinct treatment events. In this database, the most common pathologies are brain metastasis, meningiomas, and schwannomas. From this cohort, we selected patients who have undergone SRS with brain metastasis originating from lung cancer, breast cancer, or melanoma, the three most common types with CNS spread. In terms of tumor control, the outcomes that we specifically looked at were all-cause mortality and tumor progression, which we further delineate into local progression and outfield progression. The definition for these terms can be seen in my current slide right here. And subsequently, to characterize quality of life measures, we utilized the EQ5D patient-reported questionnaire, which examined 5 separate domains, which are mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. I have included a sample of the questionnaire on the right as well, and the responses. So they will be right here. In terms of the analysis, any missing data is imputed. Kaplan-Meier survival analysis and univariate or multivariate logistic regressions were used to establish the hazard ratios and endpoint of interest as well. For analysis of the quality of life factors, Parisian classification of health changes was used to describe changes over time. Better, meaning there's an improvement in at least one dimension of the EQ5D questionnaire. Worse, there's this deterioration in at least one dimension of the questionnaire. Mixed, meaning there are both improvement and deterioration in multiple domains, and unchanged. Both the total EQ5D index or total score and individual domain score were considered in the analysis. From our eligibility criteria, 522 patients were initially included. A couple points of interest from this characteristic table that I will specifically point out. The median age for the patients in this study cohort was at 66 years old. The mean EQ5D score after a conversion to an index score of 0 to 1, 0 being the worst and 1 being the best, was at 0.551. 47.8% of patients had one metastatic lesion, 35.7% had 2 to 4 lesions, and 16.3% had 5 to 14 lesions, and the majority of lesions involved the frontal lobe. In terms of tumor control, all-cause mortality was found in 137 patients with a median survival time of 27.3 months, which is reflected on the Kaplan-Meier curve shown. Local progression was recorded for 53 patients, and outfield progression was recorded in 118 patients. We also conducted a logistic regression models in terms of relative to the all-cause mortality, and we found that the presence of coronary artery disease morbidity, the presence of 5 or more lesions at a time for SRS treatment, lack of primary tumor control, intralesional hemorrhage, and Karnofsky performance score of equal or less than 90 were significantly associated with mortality. In terms of the quality of life factors, 315 patients had available EQ5D data at the time of SRS and final follow-up. Among these patients, 16.2% show no change in their index score, 34% had improvement in their index score, 35.9% show worsening, and 13.9% show mixed changes for their overall score. In terms of each individual domain, there was a relatively even spread in terms of the changes. At least 50% show no changes in mobility, self-care, and anxiety and depression. Two particular domains show the largest rate of deterioration, which were usual activities and pain and discomfort, and the self-care domain showed the smallest rate of improvement. We also further characterize these findings using a health profile grid, which is shown on the left on the screen currently. In essence, the patients above the 45-degree line show improvement, and the patients below the line shows worsening. And the further away they are from the line, the larger the changes. In addition, we also found that the patients who have stable or improved EQ5D scores perform significantly better in terms of survival, as demonstrated in the included Kaplan-Meier curves on the left. The red portions signify the patient who has stable or improved EQ5D, and the patients in the blue section are the patients with worsening EQ5D score. We also found that the two factors that were significant negative predictors of EQ5D score at final follow-up were current smokers and cumulative intracranial tumor volume, both highlighted on the right. I'll give some time for you to take a look at these tables. As I mentioned, the two factors quoted in the table on the right. Smoker has a odds ratio of 0.5 with a p-value of 0.03, and cumulative intracranial tumor volume is at 0.93 with a p-value of 0.04. And as you can see on the left as well, the median survival time for patients with worsening EQ5D score is significantly less than those with stable or improved 5D score, which is the dashed line going down to the x-axis. Overall, before I have more discussion about the results that I have presented so far, I feel that it is important to acknowledge the fact that these patients, including this study, are facing an extremely dire disease process and with oftentimes unknown or admittedly bad outcomes. As such, based on these results, we were able to highlight the ability of RSS, at least to the majority of the patients in this study, preserve their baseline functional capacity, which is crucial for them to continue living their lives and spending time with their loved ones to the best of their ability, despite their disease processes. In addition, from our observation that patients with worsening EQ5D scores perform worse in terms of mortality, present opportunity to identify these patients early on prior to their SRS treatment. Once they're identified, we can optimize them via a multidisciplinary collaborative approach with potential assistance from our psychiatry, pain palliative care, and/or social work colleagues. I also want to note that anxiety and depression has historically been underdiagnosed and undertreated for all cancer patients, which is another venue that more positive work can be done. Before I end, I do have to draw attention to a significant drawback from this analysis is that there is a lack of information about extracranial or primary disease control, which prevents the ability for us to conduct further analysis relative to these factors. Additionally, other quantitative measures such as the recursive partitioning analysis, updated recursive partitioning analysis, and graded prognostic assessment have been shown to be associated with quality of life metrics, but are not currently included in the registry. The registry is actively working on including these information, and hopefully, once they're included, this will improve future analysis. That kind of concludes my presentation about my research, and thank you so much for your attention.
Thank you, Yui. That's great. Really fantastic work. And I know I speak on behalf of Jason and Chris when I say, it's appreciated that you publish in the Journal of Neuro-Oncology with this. Um, I have to ask you, going back to some of the graphs, if you want to pull them or keep them posted up there.
Yes.
If you were going to summarize the table that shows kind of the improvements in all the different components of the EQ5D, how would you summarize, or how would you summarize this to a patient? What information do we garner from using the EQ5D as a quality of life measure for SRS for brain metastases specifically?
Um, I think that if I were talking to a patient and presenting them with the option of SRS, I think the one main point that I would emphasize for them is that this treatment method, while it has shown a lot of promises in terms of achieving tumor control itself, which is understandably the priority for a lot of the patients, it has the secondary benefit of also preserving their ability of living life on a day-to-day basis, whether it is, you know, walking their own dog around, being able to FaceTime their children, FaceTime their loved ones, having dinner. These activities sometimes are not technically considered a medical thing, but they
Mhm.
play a major role in helping these patients living a most fulfilling life to the best of their ability while they are facing these diagnoses and facing this treatment that sometimes can carry a lot of morbidities on their well-being on a day-to-day basis.
But I mean, if you go back to that table, I mean, it basically says that the majority of patients experience no change or improvements in quality of life after
Mhm.
SRS, right?
Yes.
Um, I mean, there are, yeah, obviously, being able to do your usual activities is the one that changed the most. But for the most part, it was no change or an improvement, um, which I think is it starts to ask a question of, I think, well, first of all, that's great, right? So when you talk to patients, you get to say, all right, well, most people actually are going to not change at all what you're going through right now, or improve a little bit.
Mhm.
Um, and then I guess the question becomes, what are specific factors that contribute to that outcome? Is it that the tumor control is better with SRS, or is
Mhm.
it that we're not doing harm and people are getting treated? What do you think contributes?
I think it's a little bit of both. There has been a lot of research showing that SRS is able to significantly achieve tumor control, specifically for patients who are otherwise unable to receive a more invasive intervention method, such as resection. Um, so for these patients, you have to consider the reason why they're not able to receive resection in the first place, right? They're carrying with them a lot of comorbidities, whether it is coronary artery disease, diabetes, hypertension, or that stuff. So
Yes.
I think specifically for these patients who are admittedly limited in terms of what we can offer them in terms of surgery, having this minimally invasive intervention method where we can say at the same time that one, we can control the burden of your tumor, of the metastasis to your brain, and two, it will not carry any negative effects on their daily life, day-to-day basis. I mean, consider a surgery, right? Like, would have to spend time in the hospital to recover, and there will be significantly more pain involved with the surgery. So I believe that having the confidence from a provider standpoint to say that more likely than not, there will be no change in your quality of life. And
Yeah.
in some cases, there will be an improvement in your quality of life is something I think will draw a lot of positive attention for these patients.
No, absolutely. I think the question always becomes then, is EQ5D the best measurement tool? Um, and I think I'd love to hear your thoughts on it and why you chose it when designing the study. I think that you showed the criteria that are involved in it, and obviously some of those criteria can be affected by systemic disease, not just brain disease.
Mhm.
And so just, give us a little background of why you felt that, the significance of EQ5D would be relevant here, and how we should interpret that data.
I think when we initially came up with this study and trying to talk about deciding what is the most appropriate measure to characterize quality of life, because you know it's not an easy thing to fully capture based on just one score. There are a lot of things that people do on a daily basis, a lot of things that people might place a high priority on. So what draw me initially towards the EQ5D is just how granular it goes into different aspects of life. It's talk about mobility, it talks about self-care, usual activities, pain, discomfort, anxiety, depression. Whether It's not going to be perfect. It's not going to capture the whole lived experience of a person and of a patient, but the granularity of it allows us for a more um, personalized, per se, a more specific analysis. That's what drew me towards it initially.
Yeah, I'm just the reason I'm asking is one of my personal interests is looking at cognitive function
Mhm.
and the effects of what we do, neurosurgery and radiation on functional connectivity in the brain and cognition. And so the EQ5D doesn't dive so much into cognition deficits or neurological symptoms specifically. It's really relevant though too. It's obviously commonly used in neurosurgery and oncology and whatnot.
Mhm.
And as we start to think, well, can we tailor our radiation better to not affect cognition? I always wonder, what tools do we need? What tools are we going to use to measure that? Because you can get really deep into it. You can all of a sudden you're doing a 3 hour neuropsych battery on someone, and that's making their quality of life worse, um, worse than any cancer treatment would. So yeah, that's kind of my selfish reason for asking about that. I'm looking for great ways to measure quality of life that are acceptable. And the EQ5D, I think, is a very reasonable one. What, challenges when doing this? What do you think when you were interpreting the data? Um, what were the biggest challenges for this type of research?
Um, the first one I think is that it is a patient report questionnaire. It is, in essence, a very subjective study. Um, So we have to take into account the subjective nature of that data into what we're seeing, and maybe the answer today, the patient's answer today may be a little bit different than tomorrow, just because any other random factors get involved. So just that subjective nature of the data reported is, the biggest factor that we have to try to not control for, but at least be aware of in terms of how to report our data and how to present these results of these analysis to our patients. That's the first one. And then the second kind of thing that we were considering during the analysis of this project is that the the inherent nature of the data that we included in this project is a pooled data set from a lot of different institutions across the country.
Yeah.
So a person experience in the West Coast or in Seattle, for example, or where I am right now in Northern Virginia, can be wildly different in terms of how accessible they have to, a trail where can they walk on day-to-day basis, or how they are involved in their community. So that is something that we have to take into account as well. And then lastly, it's just the inherent limitation of prospective analysis going back in time, and the associated limitations in terms of that method of doing research.
Yeah, definitely. I think it's totally reasonable. Let me ask you, what's next? All good research leads to other questions. Where do you want to take this? Or are you going to look into more components of it? Do you already have studies lined up?
Right now, as I kind of mentioned briefly in terms of the last part of my presentation, there is certain aspect of the data set that we want to improve upon. Currently, right now, there's not a lot of information about extracranial disease control specifically, and how, and understandably, that would play a big role in terms of how the patients are doing clinically and how that would affect their quality of life. If their, say, lung cancer is not controlled at the root, treating their premetastasis alone would not have a lot of significance in terms of how they're doing long term, right? So having that information included in the data set would be a great step forward in terms of how we will continue with our analysis and how to build upon this analysis specifically. And then secondly, I think that while because of our results and we are showing that, you know, these patients who have worsening EQ5D have worse outcomes and outcomes afterwards in terms of all-cause mortality. I think that building, say, like a pilot program in institution like UVA, for example, where we identify these patients early on,
Yeah.
having them filling out these questionnaires early on, identifies those patients who are a little more at risk, and optimize their treatment course by providing all the resources they need, whether it is help from our psychiatry colleagues or help from our social work colleagues in terms of having more accessibility for them, and see how and have them going through SRS treatment and see how their course has changed overall and report on that is something that we're working on, and we're talking about implementing, and well, hopefully that show positive results and that kind of so we can have more evidence to say that this works and this can provide a lot of benefits for these patients.
Yeah. Well, look, I think that that graph hits kind of the nail on the head, which is that quality of life matters for longevity.
Mhm.
Um, and and so, this is an important topic. And that's like I think one of the most important components about when we deal with this, and patient reported is the best measure of it. It's just hard to collect that data. But
Mhm.
this is important. If the patient's reported quality of life is bad, they are not living as long. And so, we have to figure that out. We have to make strides in that, whether it's prehabilitation or better patient selection
Mhm.
or, other ways to intervene and improve quality of life. It matters. And so, listen, man,
Absolutely.
commendable work. I really appreciate you taking the time to be with us here today. Looking forward to more you guys are able to put together and more data and more research, and I hope you continue to publish in the journal. We'll cut it a little bit short today, but thank you so much for being a part of it, and we look forward to seeing you guys in 2 weeks.
Thank you.
Thank you. Thanks a lot, Corey. Have a
Thank
great day,
you. Have a
everyone.
good day.
Bye-bye.